Good evening, everyone, and welcome to our series of virtual discussions head on against head and neck cancer, organized by Voice of Healthcare and supported by Merck. I'm Dr. Anoushka Amlani, moderator for today's session. While I'm humbled by this opportunity, at the same time, I'm very excited to learn from the experts on our panel today. I would like to move forward and introduce our panelists for today. Dr. R. Ranga Rao, Chairman, Paras Cancer Center, Paras Hospitals. Welcome, sir.
Thank you so
Ms.
much.
Urvashi Prasad, Director, Office of Vice Chairman, Niti Aayog. Ma'am will be joining us shortly. Dr. Shwetha, Consultant at ESIC, Model Hospital, Rajajinagar, Bengaluru. Welcome, ma'am. Dr. Rajkumar Ramaswamy, Assistant Professor, Department of Oncology, Madurai Medical College, and Government Rajaji Hospital, Madurai. Welcome,
Good
sir.
evening, everybody.
Dr. Rachana, Associate Professor, Medical Oncology, Nizam's Institute of Medical Sciences, Hyderabad. Welcome, ma'am.
Good evening and thank you.
Our discussion today will cover topics ranging from identification and differentiation of cancerous structures to symptoms, prevalence, and causative factors in India. This discussion will also explore the lifestyle choices, demographic disparities, and treatment advancements, rehabilitation needs, and many more things. Throughout this discussion, we'll be emphasizing on incorporating recent research advancements and innovative approaches to improve diagnostics, treatment, and patient outcomes. Moving forward with our panel discussions, round one, my first question is to Dr. R. Rangarao. Sir, what are the cancers of head and neck region? Can you please elaborate on what all structures that are not a part of the head and neck cancers, but which are technically anatomically aligned to the region? But and how do clinicians differentiate with those cancers?
Right. So head neck is a vast area, that we have with the head and the neck also. But then there is a brain, there are eyes, and then there are the thyroid gland. So these are not a part of the head neck cancers when we talk of head neck cancers. These are different. So brain cancers are totally different, eye cancers are totally different, and similarly the thyroid cancers or any other cancers inside the parathyroid and other they are totally different. When we say head neck cancers, we include the complete mouth or the oral cavity, the tongue, and then inside the cheeks, and then the swallowing apparatus, the piriform fossa, and all that, and then also the larynx, the voice box. These are the areas which we think of, and then apart with that are the lymph nodes. So these are conventionally head neck. And why do we group like that? Because they have a lot of similarities in them. The cause of the cancers is similar. The type of cancer is also similar. The way they present themselves is also quite similar. Symptoms could be quite different though. Sometimes the tongue cancer may present like an ulcer, and then the throat cancer inside may present with a swallowing difficulty, and so on. The symptom will be different. Their biological behavior is also somewhat different. They have a lot of common features apart from the rest things. So head neck cancers, I'm going to talk about these particular cancers only.
Thank you so much, sir. Having set the premises of the discussion, moving forward, I would like to ask Dr. Shwetha regarding the symptoms. So, ma'am, what are the most commonly seen symptoms regarding the head and neck cancers, as sir mentioned? And what is the timeline of appearance of these symptoms? When does a patient approach, feel that there's something wrong and approach the clinician? And what timeline does usually a clinician spot these symptoms in a patient?
Yeah. So when we talk about symptoms in head and neck cancer, usually we are addressing at the head and neck squamous cell carcinoma histologies, which is the most common, which constitutes like more than 90% of the head and neck cancers. And we usually talk in the same context. Like sir, Dr. Rangarao sir rightly pointed out, the symptoms vary with the site of involvement of head and neck cancers. So when we have a lip cancer, there can be a visible growth. When we have a cancer in the oral cavity or inside the mouth, there can be a non-healing ulcer. We usually say like non-healing means a ulcer persisting for more than 3 weeks in general. So a non-healing ulcer that bleeds easily on touch, that can be there. So or there can be a visible growth, or there can be an associated patch, white or red patch adjacent to the lesion, or ulcer, or there can be an elsewhere lesion also, like in the form of a red or white patch. And when we talk about tongue ulcer, tongue cancer, so there might be a restriction of movement of the tongue. So when we talk about the oropharynx cancer, there can be a difficulty in swallowing, pain during swallowing, or a sensation of foreign body in the during swallowing, or sensation of foreign body in the throat, a hoarseness of voice. When there is a nasopharynx involvement or nasopharyngeal cancer, there can be nasal blockade, or ear blockade, ear ache, and hearing disturbances, tinnitus, or sense of sensation of ringing in the ears. So those can be there. And when we consider hypopharynx or piriform sinus and other lesions, there can be a hoarseness of voice, difficulty swallowing, and pain in the throat. And when we consider larynx cancers, so there will be usually they will be associated with a nagging cough, a dry cough usually, and change in the voice. So these are usually symptoms of head and neck cancers. And sometimes we come across a particular entity called MUO neck, or metastasis of unknown origin of neck, wherein a lump or swelling can be seen in the neck, but we cannot identify a primary from where it has arisen. But we usually treat this also in the lines of head and neck squamous cell carcinoma. Hence, this also comes under head and neck cancer, and it's a symptom. So, a lump or swelling in the neck without any other symptoms, this can also be there. And to answer your second question, the timeline between diagnosis and presentation of patient. So unfortunately, in India, most of our patients present in locally advanced stages. So we don't really pick up. We don't really have our strong at early detection of cancer in oral cancer. Although it is a easily seen site, easily visible site. So I think some of the factors like lack of awareness, or sometimes negligence, so all this can contribute towards later presentation of head and neck cancers to our OPDs. So rarely we come across early stage cancer, but although picking up a cancer early could actually lead to better treatment outcomes. So unfortunately, most of our cancers are in locally advanced stages.
Thank you so much, ma'am, for your input on that. Moving forward, my next question is to Dr. Rajkumar. Based upon what Dr. Shwetha just shared, what is the status of burden of head and neck cancers in India? And since it's mostly the causative factors of cancers remain the same, but regarding head and neck, are there any specific, stronger triggering factors that are specific to head and neck cancers? Could you please shed some light on that, sir? Sir, can you please unmute yourself?
Yeah.
Yes, yes. Now you're
Sorry,
audible.
unmute. So India being in a very heterogeneous population with the different ethnicity and race being occupying the whole Indian subcontinent, so we have different habits which forms one of the triggering factors for the head and neck. The common one is the consumption of tobacco. So tobacco consumption varies in various forms from different states. In the northeast, where the smoking tobaccos are common, as well as other addictive substances are used. And in Kerala, we have a consumption, high rate of consumption of BDs and lower form of high tar content tobaccos. And we have in northern belt, where we have higher consumption of chewable tobaccos, and now the being increased incidence of smokeless tobaccos. So the TRCs are tobacco related cancers, which forms the major bulk of the head and neck cancers. Unlike in the Western population, where the virus, the HPV virus, is being one of the major drivers for the cancer, in India, still the majority are tobacco driven or tobacco related cancers, TRCs. So HPV forms a very negligent percentage, majority of being a TRCs, and mostly is the male versus female contribution more favoring the male because of the tobacco consumption, quite naturally higher in the male component rather than the female component. And the common thing is consumption of tobacco. So the tobacco cessation is very important strategy to prevent the head and neck cancers. and you need different kind of strategies and different kind of prevention effect too, because the tobacco consumption varies from different region to region in India. So you need different and the consumption of tobacco starts from a very young age, in the adolescent age, where they get hooked to these habit of tobacco. So the the main promotion to have a tobacco cessation should start very early in the adolescent age group. So mainly is the tobacco which forms the major culprit, and various forms of tobacco forms the major culprit.
Thank you so much, sir. My next question is to Dr. Rachna. Like Dr. Rajkumar just mentioned about the consumption of tobacco and its influence on the predominance of cancer in Indian patients, I would like to understand how common is head and neck cancer in comparison to other forms of cancers, and also how does the significant lifestyle and demographic prevalence of the disease, and do these, like consumption of tobacco, definitely causes cancer, but how does it interfere with the treatment and management of the disease?
Yeah. If you're speaking about the incidence of the cancer or how common it is very common. If we take both sexes together, both men and women, it is the second most common cancer. And if we consider only men, it is the topmost cancer. Like the most common cancer in men is oral cavity or the head and neck cancers, and it is very prevalent in India. We have a new Globocon data. Globocon is the global statistics which gives us about the cancer incidences and prevalences in all the countries across the globe. So coming to the Indian data, which was released recently, 2022 Globocon data, it says that we had a new cases of nearly 1.5 lakhs of oral cavity or the head and neck cancers. So one of the most prevalent cancers in India, being the topmost in men and second most common cancers among both the sexes. And coming to the lifestyle or the demographics, it is mostly seen in the age group of 50 to 60 years. That is the common age group which we see. And men are most commonly affected than females. And uh, and we also have the HPV related cancers, which are mostly the oropharyngeal cancers, which occur in a younger decades. Like compared to the non-HPV cancers, the HPV related malignancies, they do occur in a younger age group, and they do present with the early diseases. And whether these factors like the smoking or the HPV, do they affect the treatment? Majorly, they affect the staging. HPV cancers are staged separately than the non-HPV related tumors. And interference with the treatment, yes, patients who do continue smoking or chewing tobacco after diagnosis do do fare poorly compared to those who stop smoking and chewing, because it does interfere with the treatment with chemotherapies. And there is one concept of second malignancies, which is very common in head and neck cancer. If a patient initially has a cea tongue, that is a tongue malignancy, he can develop again buccal mucosa because the risk factor is same. So the patient who continues to smoke even after a diagnosis is more prone to develop a second malignancy, at which is still higher in a patient with non-HPV related malignancies. So yes, treatment part changes, and HPV related malignancies, we do have an option to prevent them by using the HPV-9 vaccine, that is the Gardasil 9 vaccine, which is available. This can be used to prevent the oropharyngeal malignancies related to HPV, which we cannot prevent unless we stop smoking or chewing tobacco for the non-HPV related cancers.
Thank you, Dr. Rachna. I would like to go back to Dr. Ranga Rao, and I would like to request you, sir, to please give a brief description about the current status of head and neck cancer screening, diagnosis, and treatment options. And it would be great if you can add to what Dr. Rachna just said regarding how can patients prevent developing a secondary primary cancer, especially with regard to head and neck cancer.
Right. So I think the first thing is, do we have a screening program in India? And the other question is, do we have any recommended screening program in head and neck cancers? Frankly, no. Because for screening, there are certain criteria which are required, that it has to reduce mortality without going to details. So there is no organized or recommended screening program for head and neck cancers. The reasons are beyond. But if you ask me personally, should we have one in India? I feel yes, very much, because as Dr. Shwetha had said, 65-70% of the patients come in stage 3 and 4. So I think there is a need to diagnose them earlier, And then there is a need to screen these tobacco chewing, because I think that has been brought out by Dr. Rajkumar and others also. Tobacco chewing is one of the important causes. So in these people, we should have a screening program. Now, who can do the screening program? The dentists, the ENT surgeons. I think they can be doing it. And the important thing is this: the screening of the the oral cavity and all that. It's very simple. A visual inspection. Now, somebody will ask, a scientist will ask, will it make the society benefit from the screening in terms of mortality? I do not know the answer because no trial has been done. But important thing is we can clinically downstage. That means instead of diagnosing them in stage 3 and 4, we can diagnose them in stage 1 and 2, which will become more amenable to treatment and cures. So that is the important thing, screening. So can I have this next part of the question, Dr. Anushka?
So the next part was, how can we prevent from patients who are already suffering from a certain kind of a head and neck cancer? How can we stop them from developing a secondary, primary, like a new form of cancer?
Right. So,
Yeah.
okay, let me just paint you a scenario. A person who has been chewing tobacco for a long time, for many years, and then he develops a condition called oral submucous fibrosis in many of the patients, and then that's just the whole parching of the entire mucous membrane in the mouth, and then they develop cancer in one place. Can we prevent a second cancer in that patient? Honestly, no, because the whole changes of the whole complete biochemical changes, microscopic changes have already happened in the entire place. So therefore, to prevent cancer coming up from there, it's like almost impossible. Yes, a person who doesn't have a submucous fibrosis, he had one cancer, then the other cancer is developing. We should just keep doing, repeated checkups, repeated examination, so that we can diagnose them early. So they should be on a regular follow-up. They should be encouraged to leave all, what you call smoking, tobacco smoking, alcohol. Alcohol and tobacco together can become a very important part in the, causation of the head neck cancer. So they could staying away from these things would help them. And the last thing is that they should have hygienic, or the hygienic habits, all the hygienic habits in terms of diet, and stay away from all these things. And a checkup, regular checkup, is that's all the thing. And antioxidants and other things, they hardly have any role. So in we can prevent, or make them diagnose earlier, that is better rather than prevention. I won't say the prevention is very much possible there.
Thank you so much, sir, for the realistic opinions. Since we have already touched the screening part, like Dr. Shwetha mentioned, my next question is to Dr. Shwetha. Ma'am, you've already mentioned how common squamous cell carcinoma is, and also the need of dental screening. So usually the idea is reducing or stopping the consumption of tobacco will reduce the development of oral cancers, which is true. But doesn't it undermine the causes like trauma from a sharp tooth edge or a prosthesis that can lead to oral cancer? And how can we incorporate oral screening by dental surgeons in this regard to impact to create an impact and address this issue?
Yeah, so whenever we talk about prevention or early detection of oral cancers, we usually aim at towards strategies against tobacco, because it constitutes like more than 85% of head and neck cancers. Tobacco is the etiological factor. So when we target the bulk, we always feel happy because it will be under control. We are not wrong in that, but yeah, we should not be neglecting other causes, sometimes preventable causes or treatable causes, some other treatable modifiable risk factors also. Like you rightly pointed out, sharp tooth is also one of the frequent cause in causing a oral cavity cancer, especially the buccal mucosa cancer. And it usually happens in a younger population compared to the actual 50 to 60 year is what we usually see in other head and neck cancers. So this usually happens during the wisdom tooth eruption, so wherein there won't be enough space for other tooth, so that comes closer to the buccal mucosa or the mucosal lining, and it can cause chronic irritation to the cheek lining. So chronic irritation is one of the causes. Other than that, like even some poor dental hygiene, poor oral hygiene, poor nutrition, so spices, unhealthy food habits, these are some of the causes. When we talk about role of dentist, so before that we need to know about the goals for screening, oral cancer screening. Usually it will be one thing is like early cancer detection. So like I already told, most of our patients are usually end up in presenting to us in locally advanced stages, wherein mortality is not an immediate issue, but morbidity is definitely an issue. That means the suffering the patient has once the cancer is diagnosed, that we can term it as morbidity. So morbidity is definitely an issue. So to decrease the morbidity, at least we definitely have a need to detect the cancer early. So dentists can definitely play a role in diagnosing or detecting cancers early, and also detecting the precancerous lesions like leukoplakia or erythroplakia, that is a white or red patch in the oral cavity. So they can, it hardly takes 5 less than 5 minutes so for a dentist to have a complete oral cavity examination. So it's a very simple technique to detect the cancers in an early stage. And when we come to the other goals of oral cancer screening, so it is about preventing the risk factors for oral cancer, like the dentist, they can play a role in advising against tobacco consumption, and in advising in changing the dental hygiene practices, so in altering their food habits, so avoiding junk. And one of the other things is like sharp tooth, so they can do a filing process, or they can have a braces, so wherein the teeth will be, I mean the tooth will be pushed little inside, so or like away from the cheek lining, so that the chronic irritation of the pricking part will be decreased, and it can reduce the risk of oral cavity cancer. So if you ask me, just like rightly the Indian Dental Association recommends, so every 6 monthly a dental evaluation or dentist visit is compulsory for all healthy individuals. It need not be at-risk individuals. Even the person who is considered to be at lower risk, they are also supposed to go to a dentist and get themselves evaluated or get a checkup done. So every 6 monthly.
Thank you so much, ma'am. My next question is to Dr. Rajkumar. Sir, apart from the conventional treatment options that are given to the patients, what are some recent advancements in treatments, and what is the level of penetration of these treatment options in tier 2 and tier 3 cities of India?
The head and neck cancers are highly heterogeneous in nature. We have the oral cavity cancers and oropharyngeal cancers, which require surgery upfront followed by an adjuvant chemo. We have the laryngeal cancers where the organ preservation is the mantra. So you go ahead and try to preserve the voice box or the larynx by giving a concurrent chemo. This is the forms of the conventional treatment. The anterior two-third of the tongue, the buccal mucosa, the tongue, and the posterior where with the surgery is the primary modality of treatment, followed by an adjuvant chemo depending upon the pathological staging of the disease. This forms the standard of treatment. In 20 years or 2 decades, the mortality rates and the survival rates has increased from 55% in 2000 to around 65%, the 5-year survival rate. But still, the morbidity and the quality of life is very poor in head and neck cancer. And they have statistics that these patients, they have a very high rate of suicidal rates are very high with the head and neck cancer when compared to the other subsites. Even though head and neck cancers are very easily amenable for early detections, we land up with the stage 3 and 4 with the poor quality of life, with the fistula formation, oral cavity. Fistula can be maybe disease per se, related to disease per se, or because of the treatment modality which being associated with. So these all leads to a poor quality of life. Not only around 65% survival rate, 5-year survival rate, you have a very poor quality of life. Not able to take the normal feeds, requires an 90G tube. Not able to have a phonation, normal voice, which requires are not able to breathe and undergoing a tracheostomy. So this kind of poor quality of life associated. That's the reason why these patients do have higher numbers of suicidal rates when compared to the other subset of the cancers. So we have moved a long way since 2000, where these conventional treatment which I talked about, surgery followed by adjuvant chemo, RT, either the cisplatin compounds or platinum compounds, the cisplatin and carboplatin, along with the external beam radiation was being used as a primary treatment for the oral cavity cancers, and the laryngopharyngeal cancers and the hypopharyngeal cancers are treated with an organ preservation strategy of undergoing concurrent chemo RT. Now we have moved into a specific molecularly driven strategy. The whole medical oncology now moved into a molecular driven where we identify the different drivers for the cancer and try to identify with different mutations by which you try to have a targeted agents either in the form of monoclonal antibodies. The monoclonal antibodies are the one which are revolutionized the treatment of the head and neck in the 2000 to 2015 era. Then from 2015 onwards, we have into the move into the era of immunotherapy, where our immune systems are tuned. The dysfunctional immune systems are tuned into act as a great weapons against these cancer cells. So the cancer cells are very smart enough to make our immune system to dysfunctional by regenerating the immune system to fight against the cancer cells, what's called an immunotherapy, by which we attack the cells. So these from 2000 onwards, we are in the era of targeted agents by either the monoclonal antibodies or small molecule inhibitors. The monoclonal antibodies which are commonly used are the cetuximab and the panitumab and nimotuzumab. These are the anti-EGFR monoclonal antibodies usually used in the head and neck cancers, either in the recurrent or metastatic setting or along with the RT, along with the chemo. Then we moved from 2015 onwards to IO therapy, that's the immunotherapy, where it is the immune regenerating drugs are given. So these immunotherapies have revolutionized the treatment of the head and neck management. So now we are talking even in the oral cavity cancers, we are not talking in terms of giving ahead of the surgery, what we call it from a neoadjuvant strategy. Ahead of the surgery, we try to give these kind of immunotherapies or targeted agents and try to downsize the tumor so that the surgeon goes and does a limited surgery, an organ preservation surgery, a minimal surgery, so that this kind of revolutionizing things has happened. And now not only in the revolution has happened, in the advancements has happened in the field of medical oncology. We have so much of advancement in the surgery. We have moved into robotic surgeries. Overall, surgeons are doing now robotic surgeries. So thoughts are robotic surgeries are being done for the oral cavity cancers without much resection of the mandibles. Earlier, people used to have so much of tissue loss, the facial dysmorphisms happens because of so much of tissues are being cut off. Now you try to preserve those organs with the help of the neoadjuvant strategy and try to do a limited surgery, organ preservation surgery. And so much of advancement has happened in the radiotherapy, in the field of radiotherapy. We have moved from the telecobalt therapies to IMRTs, where IMRTs is immunomodulated, intensity modulated radiotherapy, where the tumors are mapped and they receives the maximum dose with the nearby organs as spared from the toxic effect of the radiations. So the nearby organs, vital structures receives less amount of radiation when compared to the tumor. The tumors are painted and they receives the maximum dose of this is what's called an IMRT or intensity modulated therapy. Then from 2020 onwards in India, we have the proton therapies. The proton therapies are the one which delivers the maximum dose of the thing towards in a pencil form, a pencil-like beam, which delivers the dosage to the organ which has got the tissues which are having the cancerous cells and sparing even the nearby organs. So the toxicity is reduced, the quality of life improves. The patients who has got a recurrence in the recurrent setting can be re-irradiated with the help of proton therapy. So much of advancements has happened. But now we have the government programs are coming up in a big way, especially in Tamil Nadu, is well-established non-communicable disease programs where regional cancer centers are being done and detections are being done in an opportunistic way in the primary health center where the patients come for something else and the doctors try to have examinations. This is called opportunistic screening. And these regional cancer centers are being established in every district headquarters. So you have these IMRTs are being done now in many of the medical colleges as well as in district medical hospitals. So the reach for the patients to the nearby expertise for an oncologist, medical and is becoming more accessible. The treatment, the recent advances are becoming more accessible. But still, as I said, the quality of life is not so great. The treatments are still complicated, and out-of-pocket expenses, what you call as an OUPs, the out-of-pocket expenses are huge, especially for head and neck cancer patients. So the patient has to go a prolonged period of treatment, and the attenders has to bring him to the nearby centers, which may be few miles away from their hometown, and they have to be with the patient, and they with the loss of manpower, loss of working hours leads to a huge burden on them. So OEPs is a new concept which is being looked into. The economics of cancer treatment not only includes the treatment per se, the OEPs also forms a huge burden, and people are thinking how to reduce the OEPs or out-of-pocket expenses and try to make it more accessible and more widespread. Tamil Nadu, fortunately, has got a very good public health systems which helps in mitigating these OEPs, as well as the accessibility is also great.
Thank you so much, sir, for your detailed response regarding the penetration of the treatments in tier 2 and tier 3 cities. And since you've brought up the concept of regional differences in India and also the patient acceptance to the newer treatments, my next question is to Dr. Rachna. Ma'am, post treatment, what are the rehabilitation requirements specifically for patients suffering from head and neck cancers and have undergone those surgeries? And what are the support options to the patients have in India? And it will be great if you can just, show the regional differences, like in terms of even government policies or in general, what is available for patients in hospitals.
Yeah. So a very good question actually, and it is one of the commonly neglected part of the head and neck cancer management. Everyone speaks about the surgery, radiation, chemotherapy, and all, but what happens after this? What how are the patients going to cope up with all the treatments which we are giving and the toxicities which come up? So if we would like to speak about the oral cavity separately and the laryngeal cancer separately because they do require different kinds of rehabilitations. Oral cavity, the main problem is with swallowing. During the treatment itself, the patient faces difficulty in swallowing food. And without nutrition, tolerance to therapy or response to therapy is very poor. So, the main aim for us during the treatment and post treatment also is to maintain a proper swallowing and to avoid dysphagia. For this, proper care of the mucositis, which is a common toxicity of both radiation and chemotherapy, should be managed. They have severe pain. Proper analgesic will be helpful in reducing the pain. We have to maintain a proper nutrition, and the nutrition should be in the way the patient can take it, either the liquid diet or a semi-solid diet, which the patient can easily take. And if still after all this also, if patient is unable to swallow, then the next thing which we have and is an option of a temporary nasogastric tubes. Though it is not cosmetically appealing, but it is a requirement for the patient to maintain a proper nutrition. Who cannot take the food orally can go for a temporary nasogastric tube, which can be removed once the patient is able to have a proper nutrition. Post treatment, even then, the swallowing difficulties do persist in some patients for whom there are various postural assists or the manuals and various exercises which are available both online and at the physicians or the surgeons' clinics, which the patient needs to practice at home to improve the swallowing. And an important point is that caregivers should be educated regarding the managing the bolus. So if the patient is able to take semi-solids, then the patient attendant should try to give a semi-solid food and not force them to eat a solid food, because forcing someone who is not able to do it will lead to depression, and this depression further worsens all the problems. So proper management of the depression is also important, along with giving a proper consistency of the food and the proper amount of food which can be taken easily by the patient. This is about the swallowing difficulties. Then these patients, oral cavity patients, do also have some speech problems, which can be managed by using the tracheoesophageal voice prosthesis. And for those patients who are undergoing surgeries, where a major part, as previous speakers were speaking about, the resection of the maxilla or the resection of the tongue and all, we have an option of reconstruction, especially the autogenous tissue reconstruction, which is done by the surgeon himself, can help the patient to have a better quality of life and a proper cosmetic appeal also. And we have dentists who are specifically trained for reconstructive procedures post oral cavity surgeries. And for patients who have a laryngeal cancers, this mainly affects the vocal cords, and the patient has a problem with the speech. So for speech rehabilitation, we have different options like the tracheoesophageal prosthesis, which are various types. Some are managed by the patient itself, patient changeable prosthesis, or the physician changeable prosthesis. The patient changeable prosthesis have a shorter duration of time, that is 1 to 3 months only, but the physician changeable prosthesis have a longer of 3 to 6 months approximately. And we also have an esophageal voice. This is not a device per se, but this is the training where the esophagus is trained to produce the voice which comes out as a speech. It is a lengthy procedure, and some patients do take at least an year to get adjusted to the esophageal voice. And the other one, which we commonly see in many movies and all, is the artificial larynx, which they can place in the neck or the cheek and produce the voice. But this is more of a mechanical voice which comes out. And for the laryngeal cancer patients, they have a tracheostoma which is placed to separate the larynx and the food pipes. So this tracheostoma needs to be maintained. It should not get occluded. So we do have some stomal buttons which prevent the occlusion. And also an important point is maintaining the proper humidification of this stoma. We have a peristomal or the intrastomal devices available which maintain the humidification. So these are all the different rehabilitation processes available for patients post treatment. And coming to the support, yes, we do have various speech rehabilitation centers widely spread everywhere, both in the government and the private sectors. We have various NGOs which are helping out our patients for the speech rehabilitation. Speech rehabilitation is well known but not commonly utilized, especially for the patients coming from the rural background, because all these rehabilitation centers are in the tier 1 cities mostly. So in the rural areas, patients are not aware of the rehabilitation options available, so they do suffer from these toxicities or the side effects of therapy or the disease per se. So yes, the government should take an initiative to increase awareness regarding the rehabilitation also, not just the screening or the identification, but rehabilitation for a patient diagnosed with oral cavity cancer is very important point to maintain a better quality of life.
Thank you so much, ma'am, for your insights. Based on what you just shared with us, my next question is to Dr. Ranga Rao. So, as a clinician, as a doctor who's had such an amazing career so far, so the cases that you've come across, since the cancer aggressiveness is very different in all cases, how does the patient interact? What's the timeline of patient interaction with the doctor, and how do you address, like ma'am said, the rehabilitation part? The nutrition of the patient gets impacted. There are mental health issues. There is post-treatment toxicity from, say, metronomic therapy or traditional chemotherapy. So, how do you plan? How does the treatment plan around that, and specifically to certain cases? Like, I'm sure it might be different for different patients.
Yeah, right. Okay, so I think the most important point I want to make here is it's totally personalized. It is more personalized and more individualized than a common shirt. Even a 42 size shirt may fit many people, but here the head and neck cancer patients, every patient is different. Every patient needs are different. So we may have a patient who's on follow-up after proper treatment without any recurrence. His problem is the disfigurement. His problem is the functionality. His problem is the cosmetic things. So his problems are very different. Sometimes they may have a tracheostomy tube. Sometimes they may be having a difficulty in eating or swallowing. I think that's been only amplified very clearly. So we need to look at their nourishment, look at their cosmesis, look at their functionality in whatever way. So voice processing, many things can be done. For a patient who has got a chronic disease and it's not curable, and he's got, I think, very good has been, I mean, a lot of things has been talked about the palliation part of it. The palliation means pain is one important thing. Pain, even in the patients who have been treated, they do still have some pain, and the pain management is one important part of the head and neck cancer management. And apart from that, sometimes they have ulcers, ulceration. This also is a problem, and then we need to address them psychologically a lot so that they are motivated to continue with their life and then look after themselves, their caretaker. And the other important thing in head and neck cancers is because of the bad oral hygiene, their mouth smells a lot.
Allergies.
And even for the closer, the nearby relatives, Fine, even they detest being nearer to the people. And many times I come across questions ki, sir, my grandchildren, can they go to him? Will that cancer come to them? I mean, these are the questions. I mean, there, I would not blame the people who are asking the questions, because the gentleman is, or the lady is disfigured, and they have some, I mean, bad smell. They have something, they can't speak properly, they can't swallow properly. When such a person is sitting in front of the child, the innocent child may ask, he's my Dadaji or Nanaji. They want to go, they don't differentiate like the adults. So adults will have apprehensions. Now these are very tricky and very sensitive issues. We need to tackle them, because the child may be inquisitive. He may put his hand on the cheek and say, what happened to you here? I mean, these are very, very sensitive. So they're so individualized, so difficult at times. So we need to address the each and every patient's, the concerns, and then address them properly. So I think a lot of it has been covered, and every patient is very different. Every patient is to be addressed, and in the whatever needs are like that. So some people have a tube in the stomach because there is no food pipe proper for them to eat or drink. So then they have to manage that, and then sometimes the complications are there. Rails tube, to have a tube from the nose all the time, it's a problem. Now just telling some of the instances which have happened. So about the prognosis, one of the patients who came from Nagaland to me when I was in the previous hospital, so he had a nasopharyngeal cancer, which is very common in the northeast, and then he had a recurrence. And that time, once he had a recurrence in the supraclavicular node, other nodes, so we thought his lifespan is very limited. And then I told his newly married wife, I said, look, I mean, he's got a metastasis in such a short time, because he just finished his chemoradiation, and then within 3 months he had a recurrence in the supraclavicular node and few lung metastases. And this patient, the prognosis was predicted that he may not live for a very long time. And what happened was, after a few years, I went to Nagaland for some other thing. And then one young lady stood in front of me. He said, do you recognize me? I said, may not be. So then she said, behind me is my husband, whom you said the patient may not live for long. And here he is, completely all right. I mean, these kind of surprises happen. So the prognostication, we learn that there's no such thing as a prognostication. Every patient is different, and so that's one of the thing. And then some patient, but there's one more patient who had in 2006 a stage 4 head and neck cancer, and with simple tablet of the gefitinib, he has become all right, and he lived very well for 12 years. And then he had a recurrent second primary, which we were talking. And after the second primary, he bled so much that his life was threatened. And then we did the intervention, the treatment for him, that in the intervention radiology procedures twice, and twice he was saved. And then he came out of it. He had a feeding tube, he had a tracheostomy tube, and again, once again, with the same gefitinib tablet. And today, after many years, he's off the tube, from the tracheostomy. I never thought that he will be. And feeding tube, he's eating on his own, he's running his shop happily, and now he speaks very well with that small hole there after the post tracheostomy. So things are very, very different. And then I think, as I think Dr. Rajkumar also has said, the treatment has changed a lot. Unfortunately, there's something which is happening on ground. A common man doesn't have access to highly sophisticated treatment. And the common man, it almost, the percentage of patients of the head and neck cancers are more than 50-60% of the patients are common men. Very few belong to those category, those who can afford the immunotherapy or targeted therapy or high-end radiation or high-end surgical or high-end reconstruction, for that matter. So because reconstruction, everything is so expensive, it is beyond their means, despite having insurance, unless they're funded by the government agencies, which their numbers are very, very few. So these, most of the advanced treatment, though we keep talking very boasting about them, but I think a lot of them it's highly, highly inaccessible. What is accessible to them through the government agencies is the basic treatment of radiation, surgery, and minimal chemotherapy, and then no targeted therapy, no immunotherapy. The government cannot afford it. It's so expensive. So, and then the time. So what does it mean for us? I think there needs to be research from our side, where we can have more cost-effective procedures. For example, some of the molecules can be radiosensitizers. They could be used instead of the high-end chemotherapy and high-end molecules. So I think that kind of research is required in India, which is unfortunately not happening. Research is funded by the big companies, They want to only investigate the high end molecules, and from the west they're pushed on to us, and then we keep propagating them. I'm not saying against them, anything against them, and that should continue. But I think the low basic research which can benefit a common man must happen. And I'm glad to say that these kind of things are happening in Tata Memorial Hospital and some of the centers. They are for coming out with the, when the low end thing, like for example, metronomic therapy, oral metronomic therapy for the head neck cancers has come in from Tata Memorial Hospital, and they have proven very clearly that it's beneficial, published in many of the journals. The rest of the world may or may not adopt it, but we can adopt it. Similarly, immunotherapy, which has been used in very high doses, can be used in low doses. For example, instead of using 200 milligrams, we can use one tenth of it, 20 milligrams, every week or every 2 weeks, and so on. So the dose has become less, cost has become so less, and in one vial, two people can have like that. It's so these are the cost-effective measures, and the results are as good, if not better, than the standard procedures. So that's what it is. So, to sum it up, management of head neck cancer is highly individualized, highly personalized. We need to attend to the patient's needs, and every patient's needs are very different, and then personalize the treatment according to the personal patient's financial conditions. We should brief the family as to how to tackle this patient, for example children, and then oral hygiene and all that. We need to really address them, and people can go on. This palliation is something which needs to be really taken care of these patients in the terminal stages. They really suffer a lot, and then because the caretaker also gives up, and it's very difficult for them. So I think there has to be some good pain management, nutritional management, and multiple management, and the research has to be towards the cost effective measures in the head neck cancers. Thank you.
Thank you so much, sir, for your insight and showing us the positive side of, very dark word cancer. So it was really nice to know those stories, and also again spotting the gap in the research area. We always think that we want to research in developments and making things more, developing new. Cures and everything, but yes, India is not a country where every size fits all. So yes, that's a very great suggestion. Now we have with us Miss Urvashi Prasad. Ma'am, I request you to kindly turn on your camera.
Yeah, I don't have great bandwidth, so that's why, because you won't
Oh,
be able to hear me then. Yeah.
all right. Ma'am, we have a question for you. In your opinion, what are the main obstacles that are preventing the widespread adoption of head and neck cancer screening? And how can public health professionals address these barriers?
Yeah, I mean, I think head and neck cancers, I think much like a lot of the other cancers, we end up diagnosing those at much later stages and much more advanced stages, and I think that's a problem which is common across different types of cancers, and a large reason for that is the inability to screen at the kind of scale that is needed, and also the training, the capacity building of health professionals, especially those who are not necessarily specialists in cancer. So, because those are really the professionals with whom a patient will initially, at least early on, interface with. So, I think that is where the capacity building of the entire public health system, of every health worker, becomes very critical to at least be able to pick up some basic signs and symptoms that something is not right with a particular individual, and they need for the referral or they need for the assessment. So I think that is one area where even we in the government, we're trying to focus on, because that obviously needs a lot of attention. But of course, also systematic screening programs. I think it does become complicated because in certain cases, you need those kinds of tools to be able to do that kind of screening at scale. So sometimes those are barriers in terms of diagnostics and in terms of screening tools, which can be universalized, which can be cost effective at scale, which can be easily implemented in our very diverse and widely varying health setups across the country. But I think there are things that we can do much more simply and easily. And I think oral health in this context, because, a lot of the head and neck cancers, of course, the oropharynx is a big part of that as well. And I think in general, oral health is so critical, and that can be a very important part of school health programs, for instance. So that is something that we're trying to do, that we're really trying to re-energize the school health, program, because I think, with all these things, the earlier we bring in good habits into children, into adolescents, the earlier we are able to pick up problems. That it's always much better, rather than having to deal with everybody when they've already developed the disease and it's already at an advanced stage. So I think that is one big focus that we're trying to bring in, is through school health, and also through the health and wellness centers, which have been set up, and are being set up. We're trying to operationalize a number of primary healthcare packages through those, and a lot of those will also involve, screening, and will involve basic, health and hygiene, and will also obviously include oral health and hygiene. So I think we're trying to really strengthen the public and primary health part of it, because, like I said, obviously, whether it's health insurance, whether it is secondary tertiary care facilities, whether it is the number of specialists, oncologists, etc., all of that has to also go on in parallel. But to have an approach where we have people predominantly showing up with advanced stages of the disease is always going to be very unsustainable, and obviously not cost effective, and obviously not good for the patient themselves and their families, and society, because it's much easier and simpler, and also less costly, if you can pick up things early on. So I think we're trying to shift that whole balance of the health system, from that much more advanced late stage, or to an earlier stage, but while of course also recognizing that there are people who already have that kind of advanced disease, or who will have it, despite our best efforts at primary health and prevention and so on. And so we need to also provide for them, in terms of facilities at that level, in terms of specialists, in terms of health insurance.
Thank you so much, ma'am. You've partially answered my next question, but it'll be great if you can share some of the insights of the role of community-based organizations and the grassroots movements in raising awareness, especially about head and neck cancer, to promote the preventive measures.
Yeah, I think, community-based organizations, faith-based organizations, I think all of them play a very important role, because um, a lot of the issues, even when you look at head and neck cancers, you look at the risk factors, tobacco, both smoking as well as smokeless tobacco, and smokeless tobacco, of course, is very, very commonly used in many parts of the country. We have particular problem in, say, the northeast region, for instance, but in many other parts of the country as well. So that, or you whether it's alcohol consumption, or even other risk factors like, cervical, sorry, the HPV, the human papilloma virus infections. So I think there's awareness to be created at so many different levels about the risk factors, about the signs and symptoms of the disease, especially early signs and symptoms, which might be something very generalized. It might not even give a lay person a sense that this could be a head and neck issue, right? They might have something which could be so many other things. So even to be able to recognize some kind of an early sign or symptom, and to know where to go, where to seek help. So when we talk of awareness, I think it's awareness at multiple levels. And so it's never possible for just the government to do it alone. I think it has to be a multi-stakeholder effort where of course we have the government, but we also have the private sector, we have the medical fraternity. And like I said, when we talk of the health system, I wouldn't, in this case, just talk of the specialists or just the oncologists, but I would say doctors of all kinds, dentists, right? I mean, I think dentists should be a huge stakeholder group for the head and neck cancers. So I think we have to involve everybody, media, civil society organizations, because the task at hand is simply too vast and too huge and too complex. So I think every organization and every stakeholder has a huge role to play, especially in creating awareness, in breaking social taboos and stigmas. Even with cancer, social stigmas, taboos, they're still an issue in many parts of the country. So, breaking all of that, and making sure people reach out for help at the right time. So I think there's a lot that needs to be done, and therefore we really need a multi-stakeholder collaborative effort.
Thank you so much, ma'am. Indeed, we need a multifaceted approach to address this issue at a very earlier stage. I thank you for your insight and input. Before we wrap up today's session, I would request all our panelists to kindly give their closing remarks. We could start with Dr. Rangara.
Right. I think a lot has been said. I don't want to repeat what has been said. I have only two messages. Uh, a message for the celebrities. Do not. All right. I mean, I think Dr. Urvashi has said very clearly that the task of the prevention and screening and early diagnosis is so huge that it is impossible for the government agencies to tackle this. This has to be done at every stage. While we are unable to tackle that so much, the celebrities should not add to the problem by advertising for these things. And I don't know how to stop that. Very famous celebrities, I mean, I don't want to name them, but they have participated in one this thing. Second thing is, come to the grassroots level. Go to a village school, a primary school, or a middle class school. The teachers, all of them are chewing pans and spitting all over the place, and then you expect them to tell the children that please do not chew tobacco. I think these two simple basic things, if the children have to be told not to, I'm not talking the convent school, high-end convent schools in Delhi and when the big cities. No, the small towns and villages where the common teacher would be sleeping, and when he would be chewing tobacco and then talking, including the principal. How can you tell those children who are studying in those schools not to chew tobacco? I think if we address those kind of things, the awareness will automatically come in a lot. I mean, I think the rest has been, a lot has been said, and I leave it to the other speakers to tell the rest of things. Thank you.
Thank you so much, sir. Dr. Shwetha.
Yeah, thank you for inviting me for this wonderful session. So basically, we have covered almost everything from starting from risk factors to treatment and even advanced treatment strategies also. The only thing I want to say is like, yeah, everything has to start from childhood. So start a 6 monthly dental evaluation starting from childhood. Many schools practice it in tier one cities, but it has to be implemented at every level. So along with that, and awareness also starts from there, because whenever they go to a doctor, like all children are susceptible, or they hear their teachers and the doctors very well when compared to parents. That is a known fact. So starting from there, and we can always remove the stigma of having a cancer, so by creating more and more awareness. So and the simple message is like, whenever you have or a patient of cancer, don't segregate them. Try to help them out by being a good human being. I think that will cover most of the points. Thank you.
Thank you so much, ma'am. Dr. Rajkumar. So can you please unmute yourself?
Unlike other cancers, the head and neck cancers are highly preventable cancers. It requires a major shift from tobacco, from consumption society to a tobacco-less society. That requires from the policymakers also, great push from the policymakers also. Leave alone the accessibilities and equitability of the healthcare systems for the all privileged and privileged society. It's highly preventable diseases. Head and neck cancers are like other cancers like pancreatic cancer or any other cancer is highly preventable. You take away the tobaccos and alcohol, but it's very easily said than done, and it requires a lot of public and private collaborations from right from the policymakers like Dr. like Mrs. Urvashi Prasad to clinicians level from primary care physicians. So there's a lot of multiple stakeholders comes into play, and it's highly preventable. It can be done, doable.
Thank you so much, sir. Dr. Rachana? Dr. Rachana, you may kindly give your closing remarks.
Yes. Yeah. Yeah. Yes. So yes, as screening and diagnosis is important and periodic checkups are important, it is also important for the general public to be aware of the treatment options available, or the various treatments available for head and neck cancers, and the treatment of precancerous lesions is one important thing which will decrease the incidence of development of the cancers. So not only the cancer but the precancerous lesions have to be treated, and post treatment rehabilitation is as important for the patient as the screening and diagnosis of the cancer. So avoiding alcohol and tobacco free life and consuming a balanced nutritious diet will help maintaining a good life along with the periodic checkups as suggested by everyone. Thank you.
Thank you so much, ma'am. Miss Urvashi?
Yeah, I think I sort of in my second response I did cover, and I think the other speakers have also covered. But I would just, again emphasize that this has to be something which, of course, the multi-stakeholder aspect of it, but also I would emphasize that we have to, as much as possible, push on the prevention. As was rightly mentioned, that this is something which, yes, easier said than done, because behavioral habits, as we all know, are extremely difficult to change, and that is why we have to start young, with children, with adolescents, because that is when you're most likely to form a good habit and not get into a bad one, as opposed to changing later on in adult life. So I think that focus has to really be brought in, and I say that because the country is so large, and we just our sheer numbers are so huge that we would never have a sustainable health system if we keep keeping the focus onto the much later stages and onto the curative, and many of these conditions are not even curative when you reach a very late stage. So I think that shift, from a policy point of view, we are trying very hard to bring that in, because I think the natural tendency is to just talk about hospitals and specialists, but we ignore sometimes what needs to go in at the other end. So I think that's a balance that we're trying to bring into the system, and I would just say that we need to focus very hard on that.
Thank you so much, ma'am. I thank each and every panelist today for an amazing and thought provoking discussion. On behalf of Voice Health Healthcare, I thank you all for sharing your valuable time. Thank you so much.
Thank you. Thank you very much for this
Thank you.
opportunity.
Thank you.